Okay, now you can do one small exercise. Maybe there is our physios. We have to be dynamic. Now you place your finger just below your occiput. I think all of you can do it. Okay, below your occiput, and then poke the chin out and tuck the chin in. You just poke the chin out and tuck the chin in. Now you can see when you poke the chin out, the suboccipital muscle is going for the tightness. And a lot of research work is going on, the suboccipital muscles, the fascia, the dynamics, and how it controls your dura mater. Now what happens when we talk about suboccipital? Well, term is very sub means below the occiput. Now there are four muscles: obliquus capitis superior, obliquus capitis inferior, rectus capitis posterior major, rectus capitis posterior minor. Out of this, you see the rectus capitis posterior minor is attaching to the dura mater. Now you stand like that. Don't make any changes. Now when this suboccipital, now this rectus capitis posterior minor is attached to the dura mater, and the dura mater is covering the brain, the cranial cavity, and the spinal cord. Now what happens when the rectus capitis posterior minor, smallest but significant, that will pull the dura. And when the dura is getting pulled, now what will happen? When the dura will get pulled, now inside the cranial cavity we have the superior sagittal sinus, inferior sagittal sinus, and the transverse sinus. Three major venous systems: superior sagittal sinus, inferior, and transverse sinus. The dura is getting pulled, so it is going to restrict the venous blood flow, and that is going to cause the exertional headaches, and which is otherwise called as cervicogenic headaches. Now that is one mechanism why you get the neck pain. Neck pain, muscular imbalance, muscle tightness, trigger point, plus headaches. Then what happens? You have got sometimes person is coming and telling I have got a headache here. Neck pain and headache. What does it mean? Sternocleidomastoid trigger point, tightness, and referred pain. That is here exactly the pain comes. Very common. Person is telling I am getting the tightness here, and then that is pulling the fascia, and then here the stress comes at the terium site. What is terium? The junction of frontal, parietal, temporal, and greater wing of spinal. So there the stress comes and the headache is coming there. So that is the mechanism of cervicogenic headache in short. I can please stand here. I'll put some important slides. So this is how the international figure shows about the neck pain. Just now I explained. And the joints, major joints. You can see the upper one, occipito-atlantal joint. COC1 convex and concave, C1, C2 is a biconvex joint. And we have the facet joints. The facet joints are in the side. So that gets irritated. Please come. Now when the leg is translating forward, you can observe my leg, then the facets are getting compressed. And the facets are very highly sensitive. The mechanical threshold of the facets are very less. Now, there was one study in the year 2005 by Japanese researchers, Sakamoto and Yamasaka et al. They determined the mechanical threshold of the facet joints. 6 gram is for the facet. 70 gram is for the sacroiliac joint. 241 gram is for the anterior part of the disc. So going by that, the facets are very highly sensitive because they receive nerve supply from two levels, from the same level and from the level below. That's why it is very, very sensitive. Now what you can do is that you palpate your C2, palpate below the occiput you palpate, go a little down, you can feel the first polyprominence, that is the C2. From there you palpate 1 inch lateral, this much, 1 inch lateral and 2 millimeter down. Okay? Then you just poke the chin out, tuck the chin in. Poke it out, tuck it in. You can feel one facet, the C2, C3 facet. Just one facet, I told. Now how to detect if it is a facetal involvement? Pain comes, localized pain, you do the palpation, and as I told you, it is very sensitive, but in case of involvement, the sensitivity is becoming much more, and then it will cause localized specific pain. Okay, please go ahead. So that is how the facets gets affected, and inside the facets we have the synovial folds. So sometimes they get entrapped, and that also causes the pain. Or in case of degeneration also it causes the pain. Now you can see this video. Before you proceed for any cervical manipulation, you might be seeing a lot of videos in the reels and chiropractic manipulations. Or be very careful. Whenever you go for any kind of manipulations for cervical spine, you need to check for the VBI, vertebrovascular insufficiency. VBI. So vertebral artery is a branch of subclavian artery which is uniting to form the vascular artery, and then you need to check. How to check? Two different positions. Model. अरे आप इधर रुको. Please come. Time is limited. I told you to be here. Huh? Thank you. He's a good boy. Now the vertebral artery hemodynamics gets maximally restricted in extension and rotation position. Okay, so we have to go for that test. Be here now. Yeah? Okay. Now what are the presentations of VBI? Dizziness, diplopia, dysarthria, dysphagia, bronchitis. We have to check for that. And if the symptoms are present, listen very carefully. Do not apply any rotation manipulation. Do not apply any rotation manipulation if you get the symptoms of VBI. Now we are into harnessing technology. So I have used the ultrasonographic transcranial Doppler to depict, to measure what is the real time blood flow inside the vertebral artery. So different positions, and if possible I will see if the sound comes. Sir, is it possible to give the sound here? Sir, थोड़ा sound दे सकते हैं? सर जी, इधर थोड़ा sound दे सकते हैं? इसका sound देखिए अगर आ सकता है तो. हो सकता है क्या? ऑडियो. छोड़ दीजिए. टाइम का प्रॉब्लम है. छोड़ दीजिए. ठीक है, मैं एक्सप्लेन कर दूंगा. अरे भाई इधर गायब हो गए. इधर से गायब हो गए. ठीक है. Okay, see, I just explain here. ट्रांसक्रैनियल डॉपलर से एक्चुअली साउंड आता है वहाँ पे. जो आपका सिस्टोलिक ब्लड फ्लो है, यू विल गेट द साउंड एंड वी कैन मेजर. यू कैन सी द एम्पलीट्यूड. वी कैन मेजर द एम्पलीट्यूड, latency, real time. Then systolic velocity, diastolic velocity. So what will happen? When it gets compromised? Please, show me. Fine, that's okay. Now, when it gets compromised, I will give a very small example. आपने देखा हुआ है, suppose you have done some plantation. आप पाइप में पानी दे रहे हैं, ठीक है? You are watering the plant. आपका पाइप वहाँ पहुँच नहीं रहा है. तो what you are going to do? जो पाइप का एग्जिट है, आप उसको ब्लॉक कर देते हैं. एग्जिट को ब्लॉक करने से क्या है? क्रॉस सेक्शनल जो आउटपुट है, क्रॉस सेक्शनल एरिया इज गेटिंग reduced, so velocity will shoot up. So A1 V1 physics you have read. A1 V1 is equal to A2 V2. Now what happens when you restrict? That's what happens. When the restriction comes, the velocity will shoot up and the amplitude will increase. That is what will happen. So that we can measure. So basically we did a study to real time what is happening. Clinically क्या हो रहा है और वहाँ पे टेक्नोलॉजी लगा के क्या चेंजेस वहाँ पे मिल रहा है, वो यूज करके we can measure. And why I am telling is, maybe you have ultrasonographic, this is a transcranial Doppler. You have got a musculoskeletal Doppler unit. You have got MRIs, functional MRIs. Wherever these facilities are there, you can utilize for blending it for the purpose of research. I saw while coming electron microscopy here. Maybe some of us can take a study. What is the changes in the cellular level using the electron microscopy technique when we apply MFR, MET or stretching techniques. I mean, that is what I'm leaving it for the audience to think and ponder and apply them. Now, for the cervical spine, we can go for the PPI VMs in sideline. We can go for this technique to identify if the exact facet involvement is there or not. Somebody is getting a pen, we are checking, is it COC1, C1, C2, C2, C3, is it specifically affected? Because that is what is evidence-based practice. Then we can go for the techniques. This is one very useful technique cervical epiglide, subject in supine-like position, and we are giving anterior to posterior glide. So that is opening up of the joints, and that is also releasing the suboccipital muscles. Now, yes, this is one technique. The next technique, this is a high velocity thrust technique. But I told you that before you apply this high velocity thrust, you need to see that VVI is already tested, because otherwise it's risky. So now I am giving a thrust for right side C3, C4, putting the lateral aspect of my index, giving a rotation to the opposite side, side flexion to same side, extension, and giving a thrust to the opposite side eyeball. But before this, VVI testing is must. This is very specific technique but very useful. Manual therapy needs precision and accuracy. Now you can just work this. The scope of work for a manual therapist is just 1 to 2 millimeters just as far as the spine is concerned. So this is just one slide to kind of make you a little bit more understand. Then that is what I just discussed about neck pain and some important techniques. Next I'll just discuss a little bit about the low back pain. So these are the two conditions I'll be discussing in this version, which is more common for any musculoskeletal physiotherapist in the practice. See, this is the facet and this is the disc. Facet problems are more common for people with accentuated lumbar lordosis. Anybody with increased lordosis, with a big tummy, increased lordosis, lack of control, and stress is coming more, so facet problem is more common there. And that will lead to spondylolysis. Next, it will lead to spondylolisthesis. That we see the decapitated Scott Terrier's neck sign. So that is what happens in that. So, disc prolapse, prime cause for disc prolapse, flexion, compression, rotation. Somebody is bending forward with some twist and trying to lift. Flexion is the prime cause for the disc prolapse to happen. So that people think, should I go for flexion program, should I go for extension program? Flexion is the cause. So for cure, we have to facilitate extension line of management. So what we do, extension mobilizations, extension manipulations, and lateral shift corrections. This is the disc. This is how the prolapse happens. You can see there is a crack here. The nucleus pulposus goes out. It creates a depression. This is a Nakam-Shamsi experiment, very common. I have developed one technique called springing technique. What I found in the clinical practice is that I put a person on the physio ball so that there is extension. You have got balls at L4, L5, and when you give the mobilization, it is giving a kind of recoiling effect, and that clinically is very, very useful to treat the disc prolapse cases. Listing deviations, and we can go for the deviation correction. Yes, this is the listing. Now I'll just explain about the list. You have got the balls, say in the left side balls, person will go for listing kyphoscoliosis and listing to the opposite side. Can you please come? So how to correct the list? This is how the listing comes. See, posterolateral component is there. So you turn like this. So this will be easy to explain. They can see. Yes, listing is there to the right, balls in the left. Hold the pelvis, push from the axilla. Apply the force. Then take it for extension. Now what is happening? When we give a glide and side bending and extension, that is going to push the disc inside. Go back. So inside the facets also we have the synovial folds. Every vertebra has got 3 axes, 3 planes, 6 degrees of freedom, and total 12 moments. Now giving an example, say you are doing excessive rotation around the y-axis to the right side. Vertebra will rotate to the left. Sometimes it may get stuck. Management, you have to give a transverse glide around the y-axis from left to right. Then only the alignment will get correct. That is the specific diagnosis and specific treatment. If you give a glide from right to left, pain will immediately shoot up. You have to be very specific in identification and treatment whenever you are using manipulative therapy. Now, this is the axis X, Y, and Z. And after you do the mobilizations, you have to remember about the spinal stability programs. This is about tensegrity concept, balance of tension and compression. These are the two books I have authored. I have authored, published so many other articles, but these are the two books. And in my book, Dr. Anand was talking about, I was hearing about Lord Krishna correcting the deformity. Mine is the first publication in the world as far as the history of manual therapy is concerned. It was coming from 360 BC from Hippocrates. Mine is the first book published in the 2010 as a literature which has gone citation in so many other places. That history of manual therapy correction goes back to 3100 BC as a documented literature which is from Indian origin, where Lord Krishna corrects the deformity of three bakra with three deformities, one kyphosis and two scoliosis, one primary and other secondary scoliosis. So that is one of my contributions. And I have developed a new grading system for the fascias. Now what I observed is that whenever any joint is affected, I was talking about the facet joint or any joint, you can find there is adherence of the soft tissues. So how to quantify that adherence? I have developed this concept. There are 4 layers. Layer 1, skin, subcutaneous tissue, superficial muscle, deep muscle. According to my grading system, you can identify grade 1 is adherence of 1, 2, 3 and 4. So this is the grading system. I am not elaborating more about it. But I have done an ultrasonographic analysis of the different layers. You can see that very clearly the different layers. Layer 1, 2, 3, 4. And when we move, we can go to the individual layer and see the condition of the layer and use my grading system to see the extent of the fascial dysfunction. Other than that, since it is about innovation and technology, me and Dr. Harish Krishna, we have developed an ankle multi-axial ankle exerciser, which is working at 3 different, you can see, and along with the ISRO scientists. What we have done is, you can see the ankle and foot strategy development, stabilization can be developed, which we have put for the patterns of this device. Well, you can see this, the last 3 more slides I have. You can see this, me and my son, very old photograph. Now, these are bubbles. You can see the bubbles are there. And we tell exercises, stretching, dynamicity in life. What it does exactly? Why we tell that every day one must do 30 minutes of exercises? That basically facilitates the cellular transportation mechanism, which is very, very important. Now, we are telling that, but then we can use the gadgets to see the exactly cellular transportation mechanism, how it is happening. Now, the NCDs, the madam is there, madam has done a lot of work on NCDs, I was hearing, Glory madam. The prime cause for the non-communicable diseases and prime remedy is exercises. Because exercises facilitate the transportation system. And how the transportation system works, that is by the bubble mechanism. As the two bubbles, when it is raining, we get the bubbles. When the bubbles merge, they transfer the information. There is a transportation mechanism. The cells have the bubbling mechanism. And that bubbling mechanism, when you do MFR, bubble mechanism facilitated, or when you do exercises, that bubbling mechanism facilitated. Wherever there is lack of the transportation, that leads to non-communicable diseases like diabetes, obesity, heart attacks, and all these kind of problems. That is why exercise is the panacea. Now, Professor Rothman was awarded Nobel Prize in the year December 7 of 2013. And he has done, his lecture was Principle of Membrane Fusion in the Cell. And you can see, this is the slide where these bubbles are there and how the bubble interaction is happening. You can see somewhere in the middle, purification of vesicles and transportation mechanism. So, I think in the field of observation, medicine, chance favors only the prepared mind. And physiotherapy is a very dynamic field, emerging field, vast scope, and profession has developed like anything in the last 15 years. So I think we have got a lot of young students, and we can take up, challenging clinical work, merging with